three here. Do we have any, Dr. Min, I know may be on Zoom, and Austin Calhoun may be on Zoom, but they were not sure they would be able to make it, but I don't see them on that board. So pardon? Sure, yeah. So we had hoped to kind of take a vote and have some formal recommendations to pass along, so we may not be able to do that today. We do have some comments we're going to take. And also, there's been a few people that have contacted me. I've missed some calls and stuff. I thought we would be pressed for time. So anybody that's here today that would like to address this board, of course, it's on Zoom as well for the people that are in that. Please, I think we'll have some time to do that. So that'll be a good time to do it. And we'll take some notes on that. But we will start with Miss Angie. Are you ready? I think everybody knows you, so I don't think I'll really have to introduce you. So give us a report, please, on anything that you want to, but particularly your committee that you're chair of, which is designated primarily for research, as I understand it. And I think y'all have jumped off and really working hard on that already, is what I've heard. So.
Okay. Well, thank you so much, Jeff. I appreciate the opportunity to be here. Generally, I'm here on behalf of the patients of Mississippi as the Mississippi Cannabis Patients Alliance founder and CEO. Today, I'm here in a different capacity as the chairwoman of the Mississippi Medical Cannabis Research Board. And so that is something that SB 288 created, and that is the Medical Cannabis Research Program at the University of Mississippi, the National Center for Cannabis Research and Education. As y'all know, that facility has over 55 years of experience in cannabis of many, many different types. They have discovered over 150 different types of cannabinoids. And Dr. El-Soli really is considered the pinnacle of cannabis research after Dr. Meshulam's death a little over 2 years ago, I believe. And so it was something that I felt was really imperative in order to make the very best program for the patients and for really anybody involved in this industry, is that we needed to have a state research program. And so as Representative Yancey and Senator Black will know, I worked diligently alongside the university to make sure that this bill passed in the legislative session of 2024. And so what I want to describe to you is kind of what the advisory board is to do. We are tasked with is that we are required to advise and review research about medical cannabis and cannabinoid research activities, the status of the plans, research budget, and research findings from the National Center for Cannabis Research and Education at Ole Miss. The advisory board, it consists of 11 members, and they are as follows. The governor appointed 4 members, and that is 2 from the University of Mississippi. That's Robert Welch, who is the director, and Don Stanford, Dr. Kirk Kennard, and Levi Shepard as a patient. The lieutenant governor appointed 4 as well, and 1 is a medical cannabis research scientist. Some of you may know Blake Smith. A representative from the Department of Health, and that's Jennifer Golson. We have an advanced registered nurse practitioner, that's Megan Qualls. Medical cannabis research technologist, because we will be doing research with technology, is Tyler Dautrick. And the speaker appointed a physician experienced as a principal investigator in cannabinoid research and clinical trials. And that is Dr. Brad Ingram, as you all know, who has been over the Harper Grace bill and practices neurological medicine at the University of Mississippi Hospital. We have an epidemiologist, and we all know Dr. Thomas Dobbs, and then the patient care advocate, and that is myself. The board meets at least every 3 months. We are required to do so, but we can meet as often as necessary, in which we have met every month since September. And so we plan to be able to evaluate and make recommendations to the legislature, and that is something that is the purpose of this board. And that is to the Department of Health and to the Department of Revenue regarding the developing evidence-based guidance for treatment with medical cannabis based on the latest medical research that shall include, for each qualifying condition, a summary of the latest medical research regarding the treatment of the qualifying condition with medical cannabis. Next, risk, contraindications, side effects, and adverse reactions that are associated with medical cannabis use. The potential drug interactions between medical cannabis and medications that have been approved by the U.S. Food and Drug Administration. Next, we are to help educate recommending medical providers, pharmacy medical providers, medical cannabis card holders, and the public regarding the evidence-based guidance for treatment with medical cannabis, relevant warnings and safety information related to cannabis use, and other topics related to medical cannabis per the department. What we do is we do have a majority vote. We go by the general rules of parliamentary procedure. And so, each person has a vote. And of course, anytime there is something to be brought about for board action, it is a majority vote of the board that will rule out. And so we do have some appropriation, and that money was given through SB 3007, which was awarded $1.5 million to the University of Mississippi to the National Center for Cannabis Research and Education. And so any of our reimbursements per diem and expenditures will be reimbursed through that allocated funding there. So we already have 5 projects that are being worked on at the moment. As of July 31st, Ole Miss started getting one of 12 increments of the 1.5 million, which is $125,000 a month, to start the medical cannabis research program. And so one of the projects is they're calling it the Medical Cannabis Clearinghouse. And so that has several different divisions, and where they are looking at new medical conditions, literature reviewed, generalized anxiety disorder. They will also be looking at continuing education programs, and that has already been done. In fact, today in Oxford, they are hosting a practitioner CE day there. And then it's in February 8th, there will also be a practitioner education day here at UMMC in the Student Union. And we're really excited and thankful that the CE program at the university is involved in this, and they are actually going to issue you would actually get a CME for attending that. So if you're a physician or a pharmacist, you'll actually get a CME list for that. And so that's really exciting to have them involved, because traditionally, as you know, they weren't very involved. And so this is really exciting. We're actually starting to break down the barriers and the walls, and we're seeing that these doctors actually do want to know how medical cannabis is working for the patients. And of course, they want the patient safety to be priority. Another thing that they're doing is they will have to prepare the NCCRE a report to the Public Health and Welfare Department, which will be done alongside the Mississippi Department of Health. And that will be a report that summarizes all the things that they have going on. So not only does the board help to advise and review all of this research, the Public Health and Welfare group also works with that. And so they're also developing a brand new website that will be there to help with our practitioners and patient education. So they're really, diving in deep, the NCCRE is, and getting very, very involved with this program. The second project is the Research Funding Initiative, and that is where they can also work with federal, like the NIH, programs and things like that. And then they will be able to bring that information to where they actually can be made public. And that is one thing that the law does state, is that this research information will be made public. And I remember during Initiative 65, there were a lot of people that said, well, there's no data there. It's not been published or it wasn't collected properly. But that was one thing that I had a lot of angst against. And I was like, by George, I'm going to make sure that we have plenty of data and plenty of research and that we can share it publicly with the people of Mississippi and around the world. And so that is another reason that I felt so passionate about developing this program. The third item is that there are patient outcomes. And I know a lot of you have heard me talk about this for almost 2 years now. It's something that we've been working on with Ole Miss for almost 2 years. And that is where we will be able to use an app or a web-based tool to question patients, and they can send out reminders through text messages and different things. But we will, the Relief app or the More Better group is basically integrated. We've worked that out with the Department of Health, and so they will be able to work through the metric program to know and have those COAs and the data that they need so that when a patient puts in that they went to a dispensary and they bought this product, that information is there and the patient will not have to sit there and try to type in a name or the name of the dispensary. So it'll be far more accurate. So in the end, we'll know the patient's debilitating medical condition. We'll know the products that they're using. We'll know the COA, the information on that. And then that can be collected, and that is all done anonymously. The Department of Health and the law states clearly that they cannot share patient information, which that would be a HIPAA violation anyway. And so we will start to be able to hone in on what products potentially have better results for certain debilitating medical conditions. And so that is really, really exciting. And we hope that this is going to be something that starts as of around January 1. And so just be looking for that, because it's going to be tremendous. And we're really, really excited about that study coming about, and that will produce real world evidence data. The next is number 4 is the drug interaction studies. And, across the board, and we do know factually that medical cannabis can interact with other medications. It can either increase the efficacy or it can lessen the efficacy of a few medications. And that's really, really important for somebody to know, because they're taking their blood pressure medicine and say that cannabis, reduces it. So they may not, the efficacy of the blood pressure medicine. And so they may, need to switch out and change. And we need patients to know that, because I would dare say that everybody wants a safe program, a safe experience for the patients. And so those drug interaction studies will be done there as well. And the 5th is they are doing a CBD extract oral solution study, and that will come about through some of the information that's already been collected through the UMMC with the Harper Grace, and then they will also be studying, the CBD products and all that are on the market today. And so there's just a lot of exciting work that's going to be done, and we, as a board, are able to also advise the university as to new and endeavors that we can have them to look into and to study. And so we're always eager for input on that. So if any of you are ever want to send me some information that you feel like would make a relevant study, it's Angie@mscannapatient.com. And so I would be more than happy to share that information with the board and go from there. So, that's kind of just a broad overview of the many different things that this research advisory board can do and what the Center for Cannabis Research and Education can do. And so we're just really thankful and excited about this. And I can't thank Senator Blackwell and Representative Yancey enough for pushing this forward. And there were many other people in the Senate and House that were involved. And it is a tremendous and wonderful and exciting endeavor for our state. And so,
I know you hadn't been at it too terribly long. Have they had a chance, the doctors or the physicians, to get started on much research already? Is that kind of underway, or any particular topics, that kind of thing? Or,
topics of study.
Yeah.
They, actually, one that I'd mentioned is that we will be looking at through some evidence and that Dr. Kennard has presented to the board, and we will be potentially analyzing that data. Well, we are analyzing the data, no doubt, but we potentially will vote as to whether or not we will make that recommendation for, it to be talked about and discussed to the legislators. But that is something that, that we're going to be looking deep into. We'll do a grade system as to, the relevancy, and there's a lot that goes into evaluating the research. And so we want to make sure that anything that we do has, been researched the right way. And, we know that it has medicinal benefits and we know that it works, but we also know, and this is all I've been studying for, it seems like 2 months now, but it just happened that Leafly sent out an email yesterday and I read it, and it was about anxiety being added as a medical condition. And something that they reiterated is that more research needs to be done. And so that is something that, I go back to, and that's what we're going to do. It's just going to take a little bit of time, but I really, truly feel like our state, through the University of Mississippi, that program and this medical cannabis program will be able to solidify the facts and how it can help so many patients. But we also know that it can also create a lot of problems for patients as well. And so we want to make sure that, and studies are showing that low doses of THC and really CBD is the one that even Leafly recommended as the number one anxiety reducer, not high doses of THC. And so that's something where we do need further clarity on, when we say cannabis, which cannabinoid are we really talking about? And so we know that many of the other cannabinoids, including CBG, can be very, very beneficial.
Thank you, Angie. I saw one of your board members, Levi, and asked him to come, so you scold him for me when next time you see Levi Shepherd.
I'll do it. Thank you.
Just a quick moment of, if y'all have noticed the cameras in here, I'll introduce Brian Carpenter. He's a friend of mine, and if you don't know, he is preparing a documentary of the medical cannabis program in Mississippi. Brian Carpenter, he's preparing a documentary of the medical cannabis program in Mississippi. Brian's a Mississippi guy. He has an impressive resume of Hollywood movies, Netflix series, documentaries. He just released one for the Choctaws called Little Brother of War about stickball, which was fantastic. So if you see him in the hall and you say the right things, he'll give you a cameo or something on the way out. But we're real excited about it, and it's going to be very interesting to see it. And I think he's going to have some, I won't say the names, also some celebrities from out of town and those kind of things to kind of make it more interesting. But it's going to be real good. So look for that as it comes out. We have, is Elizabeth in yet? I know she was going to run a little bit late. Okay. All right. We'll give her a few minutes. And I'll say this we've got a list of some of the things that this committee approved last year, and it's on our agenda. One of them was changing the weekly purchase limits. That got done. We won't be able to vote on these again. These were actually approved. One was telemedicine for individuals that are homebound or bedbound in accordance with regulations that would be adopted by the Department of Health. Another one that I think is pretty important, if we can get this done, is it was about the Medical Cannabis Advisory Committee, and we had requested the legislature to consider either allowing this board to appoint 2 to 4 additional committee members with specific knowledge in cannabis, healthcare, those types of things. I don't know if it gets approved, I don't know if it would be set up that way. It would probably be through the governor or the lieutenant governor, the speaker of the house to appoint somebody. So maybe that'll get done. And also a request for some funding for this board. There's a pretty long list of the tasks that we are supposed to undertake. The ability of qualifying patients to obtain timely access to high-quality medical cannabis, the effectiveness of medical cannabis establishment in serving the needs of the patients, the effectiveness of cannabis testing facilities, including whether a sufficient number are operating, the sufficiency of the regulatory and security safeguards, any recommendations to Department of Health or Department of Revenue rules, regulations relating to all of the topics that are involved. I paraphrased a lot of that, but hopefully we can get that. If you talk to some of your legislative representatives, if that gets introduced in a bill, ask them about that, because, you know, from a reality standpoint, this board can't do a lot without having maybe an ability to contract with somebody to do a review of some of these things here, report back to us, have better communication with Department of Health, Department of Revenue, and hopefully move the needle a little bit to get a few things done. So keep that in mind. That was actually passed by this board as a recommendation last year. So hopefully that'll come back up again. One other recommendation that was passed, and that was Representative Yancey works on that a good deal, was regulating intoxicating hemp products. Also passed last year for recommendation, and I assume it would be recommended again, would be recommendation to allow medical practitioners the discretion to certify treatment of additional conditions such as anxiety and insomnia as determined appropriate by the legislature. And I think the work that Angie and her committee are doing, anytime those type issues come up, the research will be critical for that, whether it's passed or not passed, pro and con, and because that's what they need is the research. So that's going to be a great benefit to get that done. Another thing that was passed by the committee for a recommendation was for allowing transportation entities to deliver cannabis products directly to caregiver facilities, which that just makes sense for the nursing homes or aging care facilities, so that it just makes it easier. Instead of one person at a time, they could take to several patients. But that's just a little rundown on where we were on the things from last time. We've got a few things we were going to discuss today. I'll read over those. Well, I'll tell you what, I'll do that quickly, and then we'll have a little more time for comment than sometimes we usually do. So you all may have some comments on some of the things that are on the agenda today. Change the MMCEU allotment system. Change the unit equivalency from 1 unit equals 1 gram of concentrate, 100 milligrams edibles, or 3.5 of flower, to 1 unit equals 1 gram of total THC, and then a discussion about removing potency caps on both flower and concentrates. That would be up for discussion. I've really heard more discussion and comments about changing the concentrate formula than I have the flower formula. Apparently we do it different than a lot of other states. One other issue that some other folks have discussed with me and others is non-resident cards, consideration of increasing the time the card is valid from 15 days to, one recommendation I got was to 90 days, and removing the limits on the number of times a card could be renewed in a 365-day period. Another topic is a consideration of a request to remove the 2-doctor requirement on 21 to 25-year-olds. Another is the consideration to reduce the video storage time from 120 days to 60 days. It's currently 120 days for maintain all that stuff as well. But we do have another person on the agenda, and then I'll take anybody from the floor that's willing wants to make some comments, but Elizabeth is here, I understand, if you want to come on around, and I don't know if you saw where Angie was, but if you'll stand right there, please. No, yeah, come on, no, come through the middle, I'm sorry. Yeah. That's fine.
So hi, everybody. I'm Elizabeth Fader-Hosey with Mississippi Patient Voices. I'm also a cannabis patient and attorney. I've had my medical card since April of 2023. And since that time, I've been engaging with patients, non-patients, certifying practitioners, bud tenders, industry leaders, just talking to people about this program, trying to encourage people to join the program. And recently we started a digital campaign called Tell Your Stories to collect more information so that we can understand the barriers for people who want to get their card and can't, as well as addressing stigma issues and just overall trying to capture how well the program's working, because it is working well. So Mississippi Patient Voices is a political action committee, and our mission is to grow our medical cannabis program through patient-centered care, as well as supporting small businesses, because it's best for patients to have choice. And so that's why we need a lot of small businesses developing unique medicine for every unique body. And so we're collecting data from around the state to do that. At the last meeting, I heard some questions about why people aren't getting their card, especially recreational users. Why aren't they getting their cards? And so I've put together a brief report outlining what we've found so far. So the number one cause, lack of information and stigma. So the fact that the state doesn't allow advertising, or that we don't have public service announcements put on by the state, keeps the program shrouded in secrecy. A lot of times people, they still feel like they're doing something wrong. They're afraid to talk to their doctors. They're afraid to talk to people about it in general. And the information on the internet isn't super clear, and it can be an overwhelming process. So a recommendation for that would be for the state to regularly publish public service announcements to inform the public about our program. And because the state needs to be a part of breaking that stigma, because it's the state's program, the state benefits from that. And if we want to benefit, we need to encourage the public to join our safe program. And highlighting patient rights protected under the statute is another part of the PSA portion, especially given the number one piece of misinformation, is that people believe if they get their medical card that they will not be able to carry a gun or their concealed carry gun. They're afraid their Second Amendment rights will be infringed upon. This is misinformation. We know the statute clearly says that. In other states, the Attorney General has taken a more vocal approach to encourage people to get their cards. They've even allowed gun licenses to be used as a valid ID. So I think in this state, we really need to let the public know that getting your medical card will not impact your Second Amendment right. And again, these are public service announcements that the state can sponsor. If the state isn't willing to allow businesses to advertise, I think the state could responsibly advertise this program. The third reason would be cost and logistics related to getting a certifying practitioner. Patients are sometimes unable to physically visit a practitioner because they're too sick or they're too rural. Some folks have to travel over 100 miles. And I've participated in trying to facilitate patients for these people. So our card appointments for these people. So this is firsthand information that I've experienced. And so implementing telehealth for the very first appointment for those homebound people would be a great first step in addressing that. And I think that's something that you all are already thinking about. Second is, the state really needs to consider creating a reciprocity program so that patients in other states can come visit us and shop in an unlimited fashion. If they have their card, they present it at the dispensary. They pay an out-of-state fee. That creates a whole new revenue bucket. That bucket could be used to pay for patient cards, for veterans or fixed income folks. The state could easily contract with certifying practitioners around the state to supplement the cost of those cards. This weekend, I was at the Peter Anderson Festival talking to people, tons of people from Louisiana, Alabama. They want to shop medical cannabis in our state. The products are better, the pricing is better, they have more access to more products. I talk to people from all over the country who have medical in their state, they have recreational. It should be an easy thing and an easy way to get some more money to help people who can't afford to get their card. The other part is that inadequate list of qualifying conditions. Insomnia, anxiety, those come up a lot. And it's my understanding that the Department of Health could take a more proactive approach and they could specify that those two are added. An alternative would be to adopt the language under the Americans with Disabilities Act. And I put that in this report here. And I'll jump back to eliminating the 2-doctor requirement for persons in that age range. You could easily rely upon the Mississippi statute for emancipation and say that if a person is in this age range, if they are emancipated under the statute, that shouldn't apply to them. And as you know, that's full-time military service, fully supporting yourself, being married. So there's a lot of people in that age range that are adults in the world taking care of themselves, and they shouldn't have to get a 2-doctor requirement. And so that's the report that I have to present for now. We are collecting data. We're trying to get engagement from around the state, and we are happy to share data with any committee or legislator who wants to know what's going on. And we plan to track submissions related to anxiety and insomnia because we know that that's something that y'all are looking into. And then on a side note, this happened earlier today or earlier this week. I have a friend who I finally convinced to go medical because he had been buying concentrates in another state that were a much higher percentage. And so back to the concentrates, how our cap is like 50 or 60%. Other states are in the 80 to 90% range, and those products are safe. I've tried them. They are safe. So that's just a comment on that. And that's the report for today. If you have any questions.
Any questions? Thank you. Thank you, Liz. We have some time for some public comments. Would anybody like to make a comment and address the board? Yes, sir. Just come on up and state your name, please, sir. Well, let's do it here for people at Zoom.
Sorry about that. My name's Kangaroo. I got a small cultivation place in Jackson, Mississippi. I just got a couple things. One, sometimes the way the Department of Health handles me at my facility, the way they put stuff in the computer seems to be extremely unfair. So I'm gonna give you why I feel like it's unfair, and then you can make your own decision. The Department of Health comes to my facility 6 days ago. I'm waiting to leave to go deer hunting to my deer camp. I'm sitting right there waiting to leave. They pull up in my driveway. My facility badge is sitting next to me, okay? I told them, I said, I'm leaving to go to my deer hunting camp. They're like, well, we're here to inspect. Okay, you're here to inspect. So when I get the report from the Department of Health, it says, Mr. Grew is not wearing facility badge. I'm walking out the door. It's taken totally out of context from what really happened. And by omitting certain circumstances and facts, when you read these reports, it makes you look like you intentionally breaking the rules at the Department of Health. Now, I'm gonna give you example number 2. In the same report, it says, Mr. Grew has PPE available, but does not use them. What they admit from the report is, I have 0 plants in my building growing right now. 0. There's nothing in my building to protect. It's shut down. So why would I waste PPEs? And I'm not going to beat a dead horse no more. That's all I have to say on that issue. The other thing I have is a question to y'all. I never ever had a problem with the new testing regulations. Anything to make products better, I'm for. But I do have a question. Since they implementing the new testing so fast, if I make changes in my cultivation facility, you would say it would take 9 weeks of flower, so you can make changes 4 or 5 times a year. My question to you, the board, is if I grow, just say, we're going to use easy numbers for everybody to understand. If I grow a 40-pound batch, am I allowed to send a 40-pound batch to a radiating company to have it radiated to make sure it's safe for my patients, and also take R&D testing out of it? Therefore, I can dial my facility in as best possible so I don't have to use irradiate machines. And I only got one other issue and I'll sit down. The state constantly on testing, but they don't really offer no test. I mean, not testing, my bad. On this continuing education and stuff like that. But the state really doesn't offer anything, any type of education where they tell you, well, look here, go here and get your education, go to this place to get your education. It's more like of, go find it on the internet or go find it in metric and see what you get. To me, I feel like if they're going to force us to have continuing education like they do attorneys and stuff like that, they should provide a place a couple times a year where we can go and sign up and get continuing education to keep up with the state regulations. And that's all I have to say. Thank you for your time.
Thank you. Thank you, Andrew. Anybody else? If we didn't have much time, everybody would want to say something. We got plenty of time. Derek, come on up, please.
All right, good afternoon. Thank you, Chairman Webb. Senator Yancey, Blackwell, I see you on the screen there. I appreciate you being with us today. I really wish Ms. Laura could have joined us. To the other cultivator's point, we can R&D test on the product before we send it out for sterilization. So that's not a problem. I've been doing that for the past few cultivations. So everybody knows me. I am Derek Mackmer. We're Wellcraft Cultivation, Wellcraft Processing, and we also are Firecraft Cooperative. We do distribution and sales for 8 cultivators throughout the state. So we move a lot of flower. We go through a lot of testing. In our group, I've been asking the cultivators to provide R&D testing before they've been sent out for the COA testing for the total yeast and mold and the CFU count. Excuse me. What we're generally finding is that the test labs in the state are having drastically different numbers. For instance, Lab A is telling me in our cultivators that some of our strains are well within the 10,000 CFU. Some of them are just outside. We can send the exact same sample the same day to Lab B and come up with a completely and totally different range. For instance, my last one that I sent out came up with a 0 non-detectable at Lab A and a 54,000 CFU count. The exact same product was picked up within the hour by Lab B, tested through the R&D process, and came in at 53,000 for the one that detected 0, and then 58,000 for the one that detected 53,000, whatever it was. So, no, excuse me, 13,000. So the 13 was a 54, the 0 was a 58. That is too wide of a range to have consistency in our testing. The way the regulation currently reads is that if we pre-COA, in other words, before I ask lab to do a certificate of analysis, I can send it in for sterilization and irradiate the product, correct? If I do that and it tests a 0, I can have any lab pick it up. If they detect 0, they give me a clean COA. That means I can then take that flower and sell it directly to the dispensary for them to get to the patient. However, the way the regulations are currently wrote, if I take that flower and I send it in for a COA and it fails, I either have to send it to processing or to destruction. If it is acceptable for us to take in pre-COA, send in for sterilization, then it should be acceptable for post-COA inspection to do the same. It's the same flower. It could be gone through the same process. It's a paperwork problem at this point. There is no demarcation on our COAs for products that are irradiated or not irradiated. I personally have made the greatest efforts to create a facility that requires no sterilization for our products. But as you can see, using the different labs, I can't even get a good clean indication as to whether or not I'm making improvements on my facility because I'm getting such broad numbers from the different labs. I would ask that the state continue with the CFU hold and keep the 100,000 CFU limit until the labs are able to standardize that test and prove that they can have a reliable, repeatable number out of their test samples. Because from the testing that the group of people that I'm involved with in my own personal experience, it's been very, very wide range. Is there any kind of questions that you have for me?
And you're much more learned in this than I am, but is it just different testing methods, or do you know? Or is it handling, you think, or is it just the nature of testing cannabis? Or do you have an idea? I know you've studied this a lot, and I have.
Right. I know the answers to that, but it's not my place to share the lab's proprietary test measures. I will tell you that some of the state labs in the state have got higher certifications than others. I do know that some of them are ISO certified and some of them are not. I do know that some of them use a video and AI technology, more or less, to take the Petri dish and to count the potential mold spores on that dish. I've been dealing with a independent operator out of Florida that operates 13 labs throughout the United States, and they tell me that that is an unacceptable way to do a CFU count because it's unreliable. It takes the human eye to be able to identify a speck of a cannabis product from a speck of a CFU, a total yeast or mold. So that process, according to the people that I've been working with to improve my facility, is an unacceptable test method.
What is ISO? I'm sorry, I don't know.
It would be a lab certification, international standards of operation, or I'm not exactly sure what the acronym stands for. I do know that it is according to the people that I've been working with, the highest standard of accreditation.
Anybody? Yes, sir.
Yes, sir.
Mr. Magmer, will you put that in writing and email it to me, please?
Of course I will.
Thank
Yes,
you.
sir.
Thank you.
Yeah, I actually had a question. So obviously, I don't want you to name names or anything, but you think you have a pretty good feel for which lab is getting it right, which lab's getting it wrong?
Yes, sir. I do believe I do have a good feel. We've had multiple samples out of multiple cultivations sent out. Um, s- There is a lab that does seem to be more consistent with the CFU count. But it is, in my mind, still off from the processes I know that are in place to the results that I'm getting, if that makes sense.
It does. Do you think that's as a result of the testing measures they're using? Or is there some other factor in some of these labs you think is affecting the quality of the results?
That would be a question for the lab, and I would not want to tell them how to do their business.
Sure, no, I understand. I'm just wondering if if you think this is some type of personnel issue at a lab, or is this a policy decision where one type of testing just isn't reliable enough over another?
In my personal opinion, the labs are doing an exceptional job in the time frame that they've been given to perform this test at an extremely high level, and that they probably need a little bit more time to be able to reliably and consistently provide a CFU count that they can stand behind with full faith.
Thank you.
Anything else? All right. Thank you, Derek.
Yes, sir. Thank you, Chairman.
I think that touches on the point that I was discussing earlier about, if possible, if this committee had some type of budget, we could have somebody that could work with the labs, get information from the labs, find out what the labs, what they need, what they're doing, and then get us the detail you're giving in some kind of report as to maybe what their recommendation is, what it should be or shouldn't be, that kind of thing to help this committee out, but that's helpful. I think I saw another hand. Yes, go on up.
Hey, everybody. Thanks for having me. I'm in the industry. I do a lot of things, but here I come as a patient today. Thanks, Elizabeth, and thanks, Angie, for all the things that y'all have done for patients, truly. And Elizabeth brought up some really good points that I just kind of wanted to touch on coming into this legislative session. Patient rights tend to get kind of overlooked here in the state. I know we've got so much going on with the day-to-day logistics of just running the darn program. You know, our state's done a lot in a short amount of time. We really should be applauded for that. As many headaches as we have, you know, we're going to have that. It's bureaucracy. It happens. But overall, like, we've done really well, but patient rights tend to get a kind of a backseat. And that's something I really want us to focus on. I've been hearing too many DUIs simply for having a cannabis card, and a patient may be medicated at 8 in the morning, and they get pulled over at 4 in the afternoon, and a police officer or a trooper or somebody troopers are better about it, but somebody that's not as educated about it, and they just write them a DUI with no blood work, no this, there's no, I mean, Angie can tell you left and right, there's so many different studies on how to test properly and how tolerance plays an effect, things like that. That's one of the things I know they're going to be looking at. So just, putting some protections in place for patients, educating them on their rights, as well as, maybe something for, I get a lot of calls. I got a really large network. I'm very lucky. We've been pounding the pavement since day one. But one of the things that I get is a lot of scared patients about talking to their employer, or how to handle this situation or how to handle that situation. And a lot of them just get themselves in trouble by trying to be honest and working with people when that other aspect of it, the bureaucracy, is uneducated on what the real regs are. I mean, there are things in our law that protect concealed weapons, permits, constitutional carry permits. There's big misconceptions on gun laws here versus the federal. Our HIPAA makes it to where you do not have to answer that question because you have medical privacy. They can't compel you to answer that one way or the other. So that's where the kind of the legal whatever comes in. I'm not a scholar, but there's just a lot of misinformation and a lot of patient rights aspects that I feel aren't getting taken care of. And I just like to see that getting addressed this session. So thank you all.
Thank you, Mike. Anybody else? Anyone? Yes, sir.
Hi, my name is Bobby Coomer, and I'm on the processing and extraction side of things in the industry. And I'd like to thank everybody for coming here today and all the hard work you guys are doing to try to make this the best program we possibly can. I've heard a couple of people asking or having questions about the 60% cap on concentrates. And I just kind of wanted to go over that a little bit because the whole extraction and processing side of things can be a bit of a mystery to a lot of people that aren't directly involved in it in the industry. When we run extraction, there's several different ways to run extraction. From CO2 to rosin pressing to butane to ethanol, they all produce a different result. Now that result is a very concentrated amount of THC in a product. And we have to cut that product down to less than 60%. Essentially, we're taking a product that has come naturally out of the plant. It has any potential hazards have already been removed from it. And now we're forced to take something that comes out of the machine after a perfect extraction at anywhere between 70, 85%. And now the state is forcing us to cut that down to 60%. So we're adulterating a product that came out naturally that does not need to be adulterated. And that is why Miss Elizabeth made the comment earlier that in several other states, you can get stuff as high as 75, 85, 95%, depending on the extraction method used. So I hope I can shed a little bit of light on that as to we all as processors have to figure out our own way or a proprietary way to take a product that has come directly out of a machine or out of, your rosin press or whatever, and get that below the 60% so that it qualifies for the state. To me, if we're trying to provide a perfect medical product for medical patients, doesn't make a lot of sense for us to be adding adulterants to a product. Even though they may be safe, the patient isn't getting the quality product that they need. And additionally, it's more post-processing work that has to go into something that is not necessarily a necessity, in my opinion. That's sort of all I had to say, is trying to clear up a little bit on the 60% cap on the concentrates. You guys have any questions about it or anything that's shedding light on for you?
So I'm probably the only person in the room who doesn't know the answer to these questions, but I probably need to know, and you probably need me to know. So a product like Rick Simpson oil, what percent THC would that have? Is that like an 80% product or?
Yeah, so Rick Simpson oil is an unrefined, it's slightly refined, but more on the unrefined side of things. So the concentrates in that can vary depending on the flower that you're pulling from, because you can only pull the amount of THC, available in the flower. And essentially you're concentrating it down. But yes, I would say that something in the 80% range is probably accurate for that. It's going to have generally a higher amount of minor cannabinoids, which have been shown to, assist with the entourage effect of getting the full spectrum of the plant. So very beneficial for patients.
What would be the proper diagnosis for someone to need Rick Simpson oil?
Any of the qualifying conditions we currently have, I would say, as well as, many others.
And what are some other concentrates that would benefit from, what are some products, I guess, that would benefit from having the higher percentage?
So anything that's generally a concentrate is going to come out higher than that 60%. And one of my favorite products that's out there is a live resin. So it's got everything from harvest. It's kind of the industry working in complete harmony there. We've got cultivators that are cultivating phenomenal flower, fresh freezing it for us. We process it through a method, and the method extracts out all of the terpenes, a higher terpene profile, which a lot of studies have been shown that aids on the back end. It has a tremendous effect as far as efficacy and patient interaction with it. It also harnesses a lot more of the minor cannabinoids, so your CBG, which was discussed earlier, CBC, CBD, CBV, or THCV, a lot of these different compounds. So it's more of a whole spectrum. So we're not concentrating on only THC. We're adding a lot more to the mix with it because the extraction process, we're not required to add something else to it that essentially just cuts it down to get it below that 60%.
But THC is the only thing that's limited. Nothing else is limited.
You are correct, but it's very difficult to isolate just the THC and drop that down without removing other products or other aspects of it.
Okay. All right. Thank you.
Not a problem.
Yeah, I wanted to better understand because a lot of times we need to understand this better, because if we're going to do something or try to help, we don't live in the world always that you guys live in. Is there, when you're talking about, you know, you use the word adulterating the product to get it back down below the 60% level, is there some inherent harm in that you're not describing to us that you?
I wouldn't say anything that's harming anything, but you're taking a product that as it comes out of the machine or as it goes through processing, it's a very safe product. It's going to be as safe, in my opinion, probably safer, because nothing else has to be added to it. And everybody's got kind of their way that they're, you know, getting below that threshold of the 60%. But I can tell you that nobody is extracting something below 60% straight out of the plant. Like, I have never met a processor that does that. So something has to be added to it. And if by adulterate, I mean something that doesn't have to be added is having to be added to get it below that point.
I understand. So do you think is there no medical significance to needing to reduce it down below 60%? Are you suggesting that at 85, it's the same product?
I'm suggesting that I've never seen another state, medically or non-medically, put a cap on a concentrate as it comes out. And I'm saying that if I personally feel that certain people, obviously, you know, the cannabis affects different people in different ways. And certain people that higher THC content might alleviate pain in a faster manner, or it might be more effective or efficient for them as a delivery method, and provide them with more medical benefits.
Would there be, and I'm not trying to bait or anything, I'm trying to understand, are there instances in which you believe someone really needs a product below 60%?
Oh, below?
I mean, in other words, does the method to get it below 60%, do you think that's necessary in some instances for some patients?
I do not.
Okay. Thank you. I appreciate it.
Not a problem. And you're welcome to come check out our facility, and I'm happy to walk you through everything that it is that we do down there.
I think that'd be very helpful.
Absolutely.
I'd like for everybody on the board to come do that. Me being the lead person needing to be educated in that regard.
Absolutely. I know it's a small niche in the industry that, you know, people aren't quite as familiar with. And I feel like it's not the most complicated process. And once people get eyes on it and you can actually see how it goes from start to finish and all the processing that is involved in this aspect of it, it'll provide a lot of clarity, and you can sort of see what it is that we do on a daily basis.
You know, I appreciate it. I think we need to get that set up.
Not a problem. Yes, sir.
All right. Thank you, Mr. Cooper.
Thank you very much.
All right. Yes, please.
I just Googled THC caps on concentrates by state. Connecticut has 30% cap on flower, 60% on concentrate, just like we do. Vermont has 30% on flower, 60% on concentrate, just like we do. Massachusetts, no limit on flower, 70% on concentrate. You know, some don't have any limits. Washington has no limits. Colorado has no limits. Alaska, no limits. So it's all over the board. So we're not the only ones with limits. But I am open to looking at what helps the patients the most. And I know that there are patients, I specifically mentioned Rick Simpson oil. I know that there are patients who need that, and it needs to have a higher limit. And so, you know, anyway, I want you to know I hear you.
All right. Anybody else have anything on the board? Kelly, Lee, y'all have anything else you want to add? All right. So thank you for coming. We will schedule another meeting so we'll have a quorum and kind of move on with this. And the session, of course, is coming up soon. So if you have contact with your representatives or senators, tell them to be on the lookout for a bill that's submitted to ask you questions about that if they have questions, or ask people who know about those types of things. That goes a long way when you put that in front of somebody so they understand what they're looking at, like the issue that Mr. Cooper just went over. I mean, not everybody knows that stuff. So we'll work towards that process. So thank you all for coming. If there's nothing else, we will stand adjourned. Hey, I will too.